Welcome to Module 6 of OrthoEpidemiology, Diagnostic Test Characteristics 2. In the last module, we discussed validity, reliability, accuracy, and precision. In this section, we will discuss the sensitivity, specificity, positive and negative predictive value. Operating characteristics of tests are extremely important to consider when considering a novel test or even a frequently used test. These types of questions are clinically important and favorites for the OITE. The table is effectively a 2x2 table where the truth is the x-axis and the results of the test are the y-axis. You can either have a true positive, box A, a false positive, box B, a false negative, box C, or a true negative, box D. When examining a test's sensitivity, you would like to know how good a test is at being positive when the patient is sick or has the condition. It can be thought of as the true positive rate, or A, patients who test positive, over A plus C, all positive patients. You should favor sensitivity with a screening test or tests where having a false negative would likely be harmful in some way. Specificity is highly desirable in confirmatory tests, and as such it is important for it to be negative in health. Highly specific tests can help guide therapy very well because they give a greater certainty that the negative patient does not have the disease. It can also be thought of as the true negative rate, or all true negatives, patients who test negative that are actually negative, or D, over all negative tests, B plus D. You should favor specificity if your screening test is positive, or if there's an associated treatment that may be harmful or invasive. A common example of sensitivity versus specificity is the Lyme ELISA versus Western blot. The ELISA is highly sensitive but not as specific, so it will catch all potentially positive patients, but some patients may be labeled positive but not actually have the disease. As such, we need a good confirmatory test. The Western blot serves this role well. It is highly specific and rules in the diagnosis by being negative if the patient does not have the disease. Whereas sensitivity and specificity are inherent to the test, positive and negative predictive values are linked to the prevalence of the disease in the population and will get worse or better at varying levels of prevalence. This is intuitively obvious. If a test has a 95% sensitivity, another way of looking at it is that it has a 5% false positive rate. Now consider a population with a 1% prevalence. That means in the best case for 100 tests you should get 5 positive results. This would result in 4 false positives and 1 true positive for a truly abysmal 20% positive predictive value. Suppose you had a 20% prevalence. Even in the worst case with 5 false positives out of 100, you would have an 80% positive predictive value. So the positive predictive value is about the test, and the question is how likely does a true positive represent disease? It is indicated by all positive patients over all positive tests, A over A plus B. Similarly, how often can we breathe a sigh of relief with a negative test? How likely is a negative test truly negative? We measure this with all negative patients over all negative tests, D over C plus D, for negative predictive value. As mentioned before, sensitivity and specificity are fixed qualities of tests. Even for rare diseases, these remained unchanged. Positive and negative predictive values are different. Consider another example. 50% prevalence, 1,000 patients, 5% false positive rate. A over A plus C equals 500 over 550 for a positive predictive value of 90%. Now assume a 10% prevalence and a 5% false positive rate. A over A plus C equals 100 over 150. Positive predictive value 67%. Positive and negative predictive value are exquisitely linked to prevalence. This is very important to know as a doctor. Consider the example of an MRI. MRI is highly sensitive. In the early days of MRI, many incidentalomas were observed. These were MRI findings not linked to any pathology or symptom. Many were extensively worked up to varying degrees of harm. Another issue is with the lumbar spine MRI. MRI findings are often poorly correlated to symptoms. Many studies have found degenerative disc disease in asymptomatic patients at rates of up to 50%. If findings are unlikely to change one's management, one should likely forego the test. These metrics are important for the real world, because you often don't know what the patient's disease status is, so positive and negative predictive value match your clinical question more closely. In other words, you would like to know, how likely does a positive test mean that my patient has the disease? As such, by using clinical acumen, you are effectively making the prevalence of the disease higher, i.e., giving it a higher pre-test probability. Criteria for positivity. An interesting idea within surgery is a criteria for positivity, essentially dichotomizing a continuous value. So in medicine, you can say a fasting glucose of 99 is not diabetes, but a fasting glucose of 101 is concerning for diabetes. In reality, physiologically, there is likely very little difference between these numbers, but you need a cutoff value somewhere, so how do you decide? Let's take an example closer to home. This nice 70-year-old female, pictured on the right, had a total knee arthroplasty 2 weeks ago and now has pain, redness, and swelling which is increasing. You would like to know if it's infected, so you tap the knee. How do you know if it's infected? By synovial count, right? But what do you choose as your cutoff number? What if you picked 1,000 cells? How about 10,000? What are the consequences? Well, if you picked 1,000, you probably wouldn't miss any infections, but you might do some unnecessary surgery. If you picked 10,000, you probably would miss some infections, but you would likely do less unnecessary surgery. You can use math to determine an optimum cutoff. A receiver-operator curve, or receiver operating characteristics analysis, can help figure out which level would optimize sensitivity and specificity. This curve references off the gold standard, so in this case, the gold standard would be a determination of actual infection status. The inflection point of the curve would indicate optimal sensitivity and specificity. This study, for example, showed that an optimal inflection point for infection would be 27,800 cells, and that the more traditional cutoff of 3,000 cells led to more unnecessary operations. This might be okay. For example, in compartment syndrome, you would favor sensitivity because you'd rather do more fasciotomies than miss compartment syndrome. But in a more benign disease, you might favor specificity so that you wouldn't overtreat. Clinical acumen can also be used to determine cutoff. This was an interesting study which exemplifies this. Using clinical acumen, Kamath et al. Found factors which led to unplanned ICU admissions in patients following total hip arthroplasty. They used this data to come up with a strategy which triaged patients to the ICU electively and found that they decreased unplanned ICU admissions by 1/3 and drastically reduced complications. This was great. However, their co-authors found that too many patients were going to the ICU, so they had too much sensitivity and not enough specificity. Their co-authors added intraoperative factors to come up with a score and used this to keep the same good results as the previous study, but to decrease costs by placing less healthy patients in the ICU. If you have any questions, please place them in the comments section.